Good afternoon. My name is Greg Kerfman. I'm the executive editor of the New England Journal of Medicine, and I will be the moderator of this symposium on healthcare and physicians in the midst of change. Both in the Commonwealth of Massachusetts and at the national level, we have entered the era of the implementation of healthcare reform. Key stakeholders across the healthcare community are working to achieve successful healthcare delivery reform, including improvement in the coordination and efficiency of healthcare delivery, improvement in the quality and safety of care, and mitigation of the ever-rising costs of healthcare. As one political observer put it recently, we don't have a deficit problem in the country. We have a healthcare problem. These are formidable challenges for all of us. While some experts are optimistic that healthcare reform will achieve these goals, others voice serious doubts. In our symposium today, we will address these issues and get an update on where we stand and where we are headed. Our focus will be on the impact of healthcare reform on physicians and patients. To help educate us, we are fortunate to have three of the nation's most distinguished healthcare economists, each of whom has been a key contributor to healthcare reform. Michael Chernew is professor in the Department of Healthcare Policy at Harvard Medical School, and he also serves as the vice chair of the Medicare Payment Advisory Commission, MedPAC. Professor Chernew will give us an update on accountable care organizations as a means of controlling costs and improving efficiency, coordination, and quality of healthcare. David Cutler is the Otto Eckstein Professor of Applied Economics at Harvard University and a member of the Massachusetts Health Policy Commission. Professor Cutler will speak on the state policies to control the growth of healthcare spending with a specific focus on new cost containment legislation in Massachusetts. Meredith Rosenthal is Professor of Health Economics and Policy at the Harvard School of Public Health. She is a member of the Public Health Council and board chair of the Massachusetts Health Policy Partners. She will speak about transparency, the term now used to describe the provision to consumers of more information about healthcare providers, including information about quality indicators and prices of services. We'll begin with Michael Chernew.
Greg, thank you. I'm thrilled to be here. I should note that my comments are solely attributable to me, not to MedPAC, but that said, what I'm going to talk about today is new payment reforms, particularly with a focus on accountable care organizations. I'd like to put that topic in a bit of context, noting that over time, the federal spending on healthcare as a share of GDP has risen rapidly and is forecast to continue to grow rapidly. Because of that, I think the right way to interpret the discussions we're having is less about healthcare and more about taxes. That's not to say that we don't care about health, but a lot of what's motivating the discussion and reform is a concern about increased federal spending. In terms of controlling spending, there are only several strategies that one might use, broadly speaking. The first is that we charge beneficiaries more. We can either charge them more in terms of their premiums or more at the point of service when they go to the physician or the hospital. Or we might try strategies of payment reform, either paying less or paying smarter. By paying smarter, we typically mean bundling payments, either by episode or bundling them globally. I will, in a moment, focus on the last of these points, but first let me say something about the strategy of paying less. Our existing healthcare system pays physicians largely on the basis of fee-for-service, meaning that physicians and hospitals get paid for exactly what they do. What that means in that system is that organizations typically don't have an incentive to be efficient. If they can find ways to keep individuals away from the hospital or away from the doctor, they don't receive any payment for those types of services. There's very little incentive in the current fee-for-service system to coordinate care across different providers. There's mechanisms that providers can use in the existing system because of its complexity to exploit coding, and the codes are very complex and there's very many of them. There's a lot of inequities across sectors. Some Services can be paid 300% more if they're delivered in a hospital outpatient department as opposed to delivered in a physician office. This entire system creates an enormous amount of complexity. It's very administratively burdensome, and because of the fiscal concerns that I mentioned earlier, the pressures that arise under this fee-for-service system is simply to lead to falling rates, falling fees. And you see that in the Affordable Care Act, which changed the rules for updating rates in Medicare, and across the system, there's a lot of pressure for payers to lower the fees that they give to doctors and hospitals. So when we think about alternatives, it's important to understand we have to compare those alternatives not to where we'd like the system to be, which might be the way it's been with rising fees over time, but where the system is likely to go because of the fiscal pressure, which is ever falling fees for healthcare services. In that context, there's been a move towards accountable care organizations, which, broadly speaking, are networks of healthcare providers that share responsibility providing care. ACOs tend to be provider-based, either around a hospital, maybe around a large physician group. The organization is accountable for economic and clinical outcomes. Often when we think of ACOs, we emphasize the organization, but really, in general, the ACO programs are tied to particular payment models, the way the organization gets paid, and often the organization is given a global budget, a fixed amount of money to care for a patient or a patient population, and the organization is allowed to share those savings should they provide care below that budget, and in certain models they have to pay if in fact the cost of care exceeds the budget. The federal government has implemented some very specific types of accountable care organizations. There's the Shared Savings Program. There are 221 participants in this program now. They were selected by application. They're paid based on historical costs, and patients are assigned based on their use of evaluation and management services. The contracts are existing for 3 years. There's a certain size requirement. You have to have enough patients in your organization to participate. In the shared savings model, whether or not the organization faces downside risk is optional. After a while, they will transition to downside risk, but in initial contracts, you could choose only to share in the savings, but not pay if the spending is above the budget. And you're not required to work with other payers. There's 32 organizations that have been selected as pioneer ACOs, which are similar, except the organizations have to be bigger, typically more integrated, they have to accept downside risk right away, and they're required to work with other payers. Outside of the federal system, there's a lot going on at the states, and so I'll just mention a few examples. I think you could find many more. In Arkansas, there's a payment improvement initiatives in which the state and the largest, for Medicaid and the largest insurer, are sharing savings in an episode-based bundle where providers will be paid for particular types of services like knee and hip replacement. There's a range of ways of dealing with risk in that model. Oregon has a model of coordinated care organizations where there's a global payment, and there's a particular budget that includes a lot of services, and there's risk if the spending exceeds that budget, and savings for the organizations if the spending goes below that budget. I want to talk a little bit about a private example, and there are many, many private examples, but here in Massachusetts, there's something called the Alternative Quality Contract that is just one example implemented by Blue Cross Blue Shield of Massachusetts, which we've studied. In the Alternative Quality Contract model, the product was launched in 2009. It was a contract between health plans and healthcare providers. The providers join, not the enrollees. The provider groups, similar to the federal model, have to be a certain size, 5,000 members. It's only for HMO and point of service patients because in those products the patient has to pick a physician. So you're automatically enrolled if your physician signs up. If the physician you pick signs up, you're automatically in. And the primary care physician has to authorize referrals. So there's some basics of control. In that model, the provider groups face upside and downside risk, and there's quality incentives. Our analysis of it suggested, looking at the group of physicians that joined in 2009, that they saved about 6.3% in the first year, rising to about 9.9% in the second year, the groups that were not prior capitated beforehand. And the group that joined in 2010 that were not at risk initially, they saved about 5.1% in their first year. So we do see some savings. A lot of that was due to providers directing patients to lower cost facilities, but some of it, particularly in the second year, was due to changes in the use of services. In our analysis, we actually saw an increase in quality. Now, admittedly, our measures of quality are imperfect and incomplete, but we saw, for example, an increase in the indexes of quality for chronic care management and for pediatric care. And in fact, by the second year, we saw an increase additionally in adult preventive care. So at least in our evaluation of the AQC, spending went down, at least in the actual spending on medical care, and quality went up. Despite those optimistic results, I think there's a number of issues with global payment moving forward, or broadly this type of paying smarter strategy. The first one is how we set the rate. It turns out that what you spend in the global payment model is basically related to how you set the rate. So if you want spending growth to slow, you have to set a lower rate, and there's issues of how we adjust the case mix, how we allow the rate to rise over time. There's complicated organizational issues about how to allocate payment underneath the global payment across the different types of providers. There's questions about how to regulate the healthcare providers when they're bearing risk. Concerns that the savings that an organization achieves if they serve many different payers, the organization that started the contract will pay the savings, but the organizations that aren't in the contract, but are still using the same provider groups, will get a lot of the savings as the efficiencies spill over into the other insurers. And then, of course, in the end, there's an important question of who gets the savings. In many of these models, the initial savings are captured by the providers, and so it takes a while for the savings to flow through to the system overall. Nevertheless, the key thing to understand is, despite the concerns about accountable care organizations in this new model, in order to evaluate them or think about their merits, you have to compare them to the alternative. An alternative in a fee-for-service system, in general, is falling rates. My basic point is, when money gets tight, the providers want to control the money, and accountable care organizations, or like models, give them that type of flexibility and incentives for efficiency, and if you design them right, incentives for higher quality care. So, thank you.
Thank you, Mike. I always know when I hear Mike speak that I'm going to come away having learned something important, and he didn't disappoint. So, Mike, let me ask you a question about physicians. And a physician who works within an ACO has to work within a global payment and has to deal with performance incentives, typically. So why should a doctor like working within an ACO?
I think the existing system that we have, the fee-for-service system, is very constraining, particularly with falling rates. So many of the things that the physician might want to do won't be rewarded. So you're not rewarded for email contacts. You're not rewarded for efforts to keep people away from the office. You're not rewarded for better management of chronic disease. And as a result, the fiscal pressures make rates drop and drop and drop, and so physicians are under a lot of financial pressure. In an ACO, physicians, more broadly the physician group, and even more broadly than that, the provider group overall, they can share the savings of efficiency, and there's a lot more flexibility to capture the savings when they practice in a more efficient manner. And I think in the end of the day, physicians that want autonomy for how they practice are better off being accountable for the overall quality and spending of care, as opposed to trying to deliver care piecemeal, where the fiscal pressures will put them under greater financial scrutiny and greater practice scrutiny, with a lot more administrative rules like utilization review and other types of strategies that in a fee-for-service world are often put in place in order to prevent excess utilization of services, but in an accountable care organization world, you rely on the incentives and you don't require such micro-monitoring of physicians.
Okay, well put. But is there any possibility that ACOs could actually end up being detrimental to the quality of care?
This is the big concern, and I have to say that research is in early stages of this. The concern, of course, is that if you pay physicians a fixed amount, they have no incentive to provide enough care. In fact, the financial incentives are to provide insufficient amount of care. There's a number of factors that I think cut against that basic analysis, including the fact that most of the new models have quality measures, so there's some incentive for providing better quality, and I think those types of quality measures will help guard against it, but as many people have pointed out, those quality measures are incomplete. But I think there's other aspects of the program that would help promote quality. For one, if the provider system can keep patients healthier, they avoid the costs of readmissions. They avoid the cost of adverse events. So there's a lot of incentives in this model to keep a population of people healthy, which you would not see in a standard fee-for-service model. So a lot of what these accountable care organizations do is they think about how can we manage our patients with chronic disease better, because they're trying to avoid the bad health outcomes that often accompany chronic disease. So there's many reasons why we don't want people to have a heart attack, but in an ACO, you don't only try and avoid the heart attack because you care about your patients, you actually save money when you avoid the heart attack. So I think that there's some reasons to be optimistic for accountable care organizations, but certainly better quality measurement systems and certainly better monitoring of what's happening will be important.
One last question, Mike. As you know, recently, Clayton Christensen at the Harvard Business School wrote an op-ed in the Wall Street Journal in which he raised concerns about whether ACOs could actually be successful. So the question that I will ask you is, what are the biggest risks to success of ACO programs?
And again, that's a valid question. I think skeptics would say that we've had certain types of models like this in a long time, and they haven't always met with success. I think the biggest risk is the ability of the healthcare delivery system to work within a reasonable budget for care. Now, what I would say, and I think those are valid concerns, what I would say is one way or another, we are going to control healthcare spending. So if the providers can't control healthcare spending when they have incentives to do it, we have to recognize that the alternatives could be much more draconian. I think that we need better IT systems. I think we need different organizations that are really focused on transforming the way care is delivered. And it's certainly possible that not all organizations will be successful in doing that. So with added work, there's a big industry now in helping these organizations transform. We have to hope that they can do it because, again, the alternative isn't going back to a fee-for-service system the way we practiced it in the mid-'80s. The alternative is going to be something that I think would face different, although similar risks to providers as the payers refuse to spend what the providers would like them to spend. And that's where I think the big challenge is. And we will just have to see how well the healthcare system can reform, recognizing that they don't have as cushy of a fee-for-service system to go back into that they might have had in decades past.
Thanks so much, Mike. We appreciate that overview, and it's going to be very interesting to see how ACOs affect medical practice in the next few years. We're going to turn now to David Cutler, who will speak to us on state policies to control the growth of healthcare spending. David?
Thank you, Greg, and the Massachusetts Medical Society for inviting me to come here. I want to pick up on where Professor Chernow left off, which is what states are doing to address healthcare spending and the imperative there, and also provide a little bit of an answer to a trivia question. The trivia question is, what do the states of Arkansas, Oregon, and Massachusetts all have in common beyond that they're all in the United States? So I will focus primarily on Massachusetts, but I want to bring in reference to the other states as well. And I want to start off exactly where Professor Chernow started off, which is the budget problem. So state actions on healthcare are picking up speed. They've always been there. States have enormous budget problems. You can see in Massachusetts in the past decade or so, spending on healthcare in all of its guises, whether it's mass health or state employees or other kinds of programs, has increased, and everything else in the budget has been cut. The issue is much more severe for state governments than for the federal government, because state governments cannot borrow to the extent that the federal government can. So they can't, some of them can't run deficits at all, some of them have to run deficits in expectation, or balanced budgets and expectations. So the net effect is that the state budgets are very severely strained. In Massachusetts, where we've committed to cover everybody, it became very difficult to make ends meet during the recent recession when revenues were down and claims on the government were up, but we didn't know what to do about healthcare. The governor got very frustrated, as have governors across the country. where states are going with this is they say we have to address healthcare spending. They think about it partly in the state budget context, which is how much is the state government spending on healthcare. But the other thing they're acutely aware of is that if the state government spends less, either by paying less for their Medicaid programs or by paying less for their state employees, traditionally those costs have just been shifted to private firms. So the providers would mark up the rates to the private insurers. And many governors are acutely aware of this, particularly when businesses come in and say, why are you doing this to us? It's in essence a hidden tax increase, and nobody wants to pay for tax increases, whether hidden or not. So the states are responding by saying we really have to go at medical spending as a whole, not just the state component of it, not just our own particular employees or the people we're responsible for, but everything. They're aided in that fact, if you want to call it aided, by the fact that it is generally believed, and I mean very widely believed, that an enormous amount of medical spending is believed to be wasted. So a guess that runs around among health economists with a fair degree of cohesion around this number is that about 1/3 of medical spending is believed to be unnecessary or not appropriate. And that comes in a number of different guises: care received that's above where it needs to be received. Michael was talking about, Professor Chernow was talking about some of the things that ACOs try and do to reduce the prices that they pay and where people use services, administrative expenses that are just unnecessary, and a variety of other kinds of things. So that's been the agenda for states and dealing with their medical problems. And then the question is, what do you do? How do you address that? So let me tell you what it is that the advice that they're getting, what it is that economics has to say about that, and how it's likely to play out. So if you say to economists, okay, what would you do about that excessive spending? The first thing you'd say is find a better way to engage the consumer in all of this. And I know that Professor Rosenthal is going to talk about this, so I'm just going to be very general here. But there are really two ways to do that. One is through choice of insurance. That is, have individuals face a well-functioning insurance exchange where they can choose amongst different plans, including plans that may make it more difficult to go to very expensive providers, at least where those very expensive providers are treating them for services for which they've not been shown to be superior quality, so routine services. Those products are very rapidly growing, particularly among small and mid-sized firms that want to keep some amount of generous coverage but can't afford overall choice. We've had that in Massachusetts for a number of years. The thing that's new and really interesting in Massachusetts with the recent health legislation called Chapter 224, passed at the end of the summer in 2012, is that there's now a requirement that insurers provide real-time data to individuals on price and quality of services wherever they may receive them for whatever kinds of services they may receive them. There was an article in a medical journal a few months ago about an individual who tried to call around and get the price of a routine surgery. And at half the places he called, they wouldn't give him a price. The other half searched around, and the prices that he got were on the order of $10,000 to $100,000. So that's just an example of how difficult this is. The hope is that by October, when this goes into effect in Massachusetts, when this requirement goes into effect in Massachusetts, individuals and the physicians who are advising them will be able to pull up and, as I said, in real time, find out how much would that surgery cost, what do we know about the quality of different organizations, and therefore make a good decision about where people should receive it. So that is going to be very welcome for consumers and hopefully for physicians as well, who really don't want to refer people in circumstances where the individual is then going to be very frustrated, have to pay a lot of money and not be sure whether it was worth it. So that's the first area. The second area, which is also extremely important, is what Professor Chernow was saying, which is to try and move away from insurance reimbursement systems that pay on the basis of strictly what's done and pay more on a global or an integrated basis. In the Massachusetts legislation, this is called alternative payment systems, which really represents a variety of different bundled strategies, ranging from strategies that pay for acute care episodes, hips, knees, cardiac conditions, cancer, whatever it is where you start off with an acute episode, into more global payments for a patient as a whole, whether it's for at the chronic care level or, let's say, for a patient for a particular year. This has a long history in Massachusetts. In 2009, we had a special commission that recommended that all payments for medical care in Massachusetts transition into a patient-centered global payment system within 5 years. The legislation did not do that, but it very substantially encouraged this, and it's there's a transition that's going that's ongoing in addition to in the private sector, as Professor Chernew said, but with state employees, with the Mass Health Program, with a variety of other payers as well. Massachusetts is not the only state to think this way. In Arkansas, they have written into legislation 5 conditions for which global payments are required, and they're going to add to that over time. And in Oregon, in the Medicaid program, they, in essence, got $2 billion from the federal government up front to create a network of coordinated care organizations. Those organizations will be responsible, there are 15 of them, they'll be responsible for care of Oregonians in the Medicaid program over the course of the next several years, and the state has promised to save the money to pay back the federal government the $2 billion that was lent to it, and those organizations are really on the financial hook for that. And what they're relying upon is the power of these incentives, putting, as Professor Chernew said, putting the money in the hands of the providers and saying, you figure out how to deal with these people, but we're not going to be paying you more just because you do more. They will condition them, as Massachusetts is doing with many of its global payment systems, on the quality of care provided, but not necessarily on the quantity of care provided. There are a number of other steps in this. One of the things that almost all provider systems really say they want, and they've had difficulty getting, is data sharing. So they want feedback on patient use, both in real time, that is when the patient goes in the hospital, how can I know that so I can figure out what went wrong and help the patient, as well as more sporadically to understand where their patients are using services and where they should be addressing the utilization of those services. There was a component of medical malpractice reform, which actually there was common ground found between the Massachusetts Medical Society and the Massachusetts Trial Lawyers Association, which is very rare nationally, but was quite welcome here, where what we've done is we've moved towards what's sort of being called the Michigan model, which is where there's early disclosure and transparency associated with medical errors, often an early settlement, apologies. The apology is not admissible in court, but it's a way for the provider to express to the patient their unhappiness as to what happened with the patient. And what the evidence suggests is that that leads to actually fewer lawsuits and fewer claims, even though many providers are afraid it will lead to the opposite. But I think it was a very, very welcome change in the malpractice environment. And finally, the legislation is trying to do things on administrative simplification, which is an enormous waste. The waste is probably about 10 to 15% of medical care spending in the country is on wasted administrative services. There's not an enormous amount that any particular state can do. A lot of it is federal, associated with the requirements for transmitting data back and forth, although Massachusetts has been one of the leading states in dealing with administrative simplification, along with states like Washington State and Minnesota and a couple of others. And we're trying to push more along those lines in that legislation. The legislation also set a target, and many states are really thinking about what kind of target they want for medical spending. It's easy to see where they're going to get a target, which is by reference to the economy. So the economy is growing about 4% a year, roughly, in most states. It'll slow down a little bit as the population does not increase as rapidly, but it'll grow by about 4% a year, which means that tax revenues are growing about 4% a year. Historically, medical spending has been increasing about 5.5% to 6% a year. Well, anytime that your spending is increasing more rapidly than your revenues, you've got a problem. You don't need to be an economist to see that, although sometimes it's easier to point it out that way. Premiums are growing more rapidly than that. They're growing about 8% a year. What that reflects is the fact that those are private premiums, and the government spending is increasing less. That is, the government is shifting costs to the private sector, and that's, of course, what we're talking about the states we're trying to get rid of. But the obvious benchmark is to say, look, for at least some period of time, we've got to provide relief for the state budget, and that means that healthcare can grow no more rapidly than the growth of the state economy. So in Massachusetts, the legislation actually set targets, which is that the growth of medical care will be at the growth of the state potential economy. Think about that just as a long-run average growth of the economy. And then it ought to fall below that for some period of time to provide some relief to the federal budget. And by the way, since it's total spending, that will also provide relief to businesses whose labor costs are increasing roughly with the growth of the economy, and to families whose household income is increasing roughly at the growth rate of the economy. So the idea was to reduce the footprint of healthcare, not by slash and burn, which is typically the way that the federal government thinks about doing it, but by gradually reallocating the resources in exactly the way that Professor Chernew was saying, which is to try and rationalize things so that we don't need so many of some services, and thus we don't hire as many people or move as many people into there, free up some of that labor, either for other things in the medical system that need it, or to go outside of the medical system, teaching, engineering, a variety of other claims that have been starved because of healthcare's growing importance. So the target is unique to Massachusetts, but that kind of a goal is not. And as more states deal with this, I think we're going to see many more exploring those kinds of targets as well. The consequences for any state would be enormous. In Massachusetts, what we were looking at as this legislation was being discussed was savings on the order of $150, $160 billion over the next 15 years or so, from roughly a $65 to $70 billion healthcare economy now, growing rapidly over time. The interesting thing about the legislation in Massachusetts, as this was being discussed, most of the groups, including physician groups and payer groups, did not come in and say that this was a bad target. They discussed a little bit what the exact number was and whether it was too high or too low, but actually that was not important. Everyone realized we had to do something because, as Professor Chernew said, and I'm sure Professor Rosenthal will say as well, there's no way we can avoid doing something. So the issue is not that. The issue is, are you doing the kinds of things that will help them to contribute to making the growth of costs be less rapid? And that's exactly the sort of discussion that we had about what are those key priorities, and that's really what worked its way into the legislation. There's a fairly good head start for this, which is that the growth rate of medical spending has actually been relatively low recently. Other than a period in the early 2000s where providers were consolidating and thus able to raise prices, medical spending growth has actually been relatively low. That was both encouraging for Massachusetts and states like it, in the sense that they said, look, we have some sense that we can do this, and also made them a little bit more ambitious in their goals. That is, they said, if this is what happens without putting a lot of emphasis into it, maybe when we put more emphasis into doing the right thing, we can achieve even better outcomes. So this kind of chart makes one think that maybe we're on the cusp of bending the cost curve, or maybe we've already found some of the secrets to do that. We just need to do more about it. The other way to think about this is in a sort of more global context. What states are really trying to do is get around many of the sort of stale debates that have been had between single payer systems on the one hand, that say we ought to put everybody into a common insurance framework and just lower prices, and the sort of wild west of unfettered consumer sovereignty, which is, go out in the market and God bless you and see what you can figure out, which, as the article about the surgical procedure shows, we're nowhere near able to do, but rather to try and draw from across the spectrum, ranging from increasing cost sharing when using services as appropriate, to changing the payment system under which the providers operate, to doing things about administrative waste on the one hand. And so there's much more of a kind of Catholic approach than you see at the federal level, which is very much of a kind of I'm going to battle you over what my favorite strategy is. So that's where a number of states are. Massachusetts is probably the furthest along, but I don't think it's going to be out on its own for a long time, the way it was with, say, coverage, where other states really just didn't feel like they could do it. I think this is much more pressing, and there's going to be a lot more spread rapidly of these kinds of models.
Thank you, David. And I'm glad you've ended on a relatively optimistic note. But let me challenge you a little bit about this. In a recent interview that was published in the New England Journal of Medicine with Paul Ginsberg, who's the president of the Center for Studying Healthcare System Change, Paul expressed skepticism that the health spending target in Massachusetts can actually be met. He believes that the new law communicates aspirations, but lacks teeth, those are his words, and does not contain sufficient concrete steps to control spending. So how would you respond to Paul Ginsberg?
So let me say two things. First is Dr. Ginsberg is right in some respects, which is that the consequences for failing to meet the target are not very severe. And they were purposely so. That is, if the target is not met, there's no organization that will go in and impose rate constraints, that will impose price reductions, that will impose closing hospitals or shutting down physician practices or whatever it is. There is none of that in the legislation, and no one wanted that. Here's sort of what we know, which is if you try and regulate the end point, which is just the spending, you won't succeed. So that's kind of the mess that we got into with the SGR in Washington, which is we said we're not going to do anything about the underlying incentives driving the system. We're just going to impose this overall cap. And we know that if you impose an overall cap without changing the underlying incentives, you won't achieve that, and you'll just be unhappy. What this legislation was designed to do was say, I'm going to be lighter on the overall cap, but I'm going to be much stronger in the underlying incentives driving the system. Those being the incentives for the patients and how they seek using care, and for the providers in how they go about interacting with the reimbursement system and the insurance system more generally. And once you do that, it's the hope of most people that you will have reached a situation where cost increases will have moderated, and you won't have to think about imposing any kind of regulatory strategy. So it's very much a strategy not built on regulation, but built on sort of changing the way the system is operating to get to that, and having the target there as a means of focusing attention, which actually has turned out to be very important because it now has given insurers and payer groups and providers something that says, here's where we need to be, and how do we think about what we need to do to get ourselves there, which is a very good position.
So to pick up on that, how are you going to measure success in the cost containment program? Is it simply meeting the spending target? Part of that target? Are you going to be happy if you get partway there? Or will you also consider other factors such as quality and outcome measures?
The legislation is concerned rightly with both the cost of medical care and the quality of medical care. So it's obviously very focused on cost, and so there's a metric put into the legislation, which is if costs increase more rapidly than the state economy, then certain actions have to occur, not regulatory actions, but certain actions have to occur. If we do that, though, in the same way that the managed care era did it, by lots of hassles and the perception that the quality of care was falling, then no matter where we'll be on the cost trend, the thing will fail because it will fall apart. So if what happens is a few years from now you go to the doctor and the doctor says, I really think you need an image, but I can't give it to you because we're on a new cost diet in our organization and we're not allowed to do images, then we might as well admit defeat. At that point, the legislation will go away, everything will go away, and we'll have to try something else. If what happens is you go to the doctor and the doctor says, actually, I want to figure out how we can help keep you healthy, and we've got now a system in place that we didn't used to have. And I see here the areas in which you've done well, and I see here the areas in which you've done poorly. And I want us to figure out how we're going to address the things that have done poorly so that we don't need you to use those services down the road, and you can be healthier and spend less money. Then that will be an enormous success, and people will like it, and physicians will like it too. And so the sort of quantitative benchmark is going to be on the cost, but the real measure of success is going to be on how it plays out in patient-physician interactions.
Well, thank you, David. I guess I would be stating the obvious to say that this is a landmark piece of legislation, and it's going to be very carefully watched across the nation. We're now going to turn to Meredith Rosenthal, who's going to speak to us about transparency and providing consumers with more information about healthcare providers, which they then use to make decisions about who to go to. Meredith?
Thank you, Greg. Thank you to the Medical Society for including me in this panel. So I'm going to pick up on a couple of threads that the previous speakers have begun for us. And I would say that while it's true that current reforms, both at the federal and state level, have focused on provider payment, they're also apparently conscious of the need to engage consumers. David had a nice sort of spectrum of cost control, delivery system reform strategies, as it were. And those include much more regulatory approaches and more free market approaches. And often the conversation around the need for cost control has some ideological content to it, and we think about consumerism and consumer reforms on that free market side. But I think it's really important to understand that there's a necessary interplay between bringing patients, consumers along in terms of their understanding of the cost and value of healthcare and changing the delivery system through whatever set of payment reforms. The Affordable Care Act includes a number of provisions that largely strengthen the infrastructure for quality measurement and cost reporting as well. Largely through the Medicare program, but also through development of a national quality infrastructure. Likewise, Chapter 224 includes a number of key items. In particular, it requires health plans to make available to patients, as David was saying, in real time, cost information, not only for a procedure, but also across providers, so that now patients will be able to get information from their plans about exactly how much an MRI, a CT is going to cost, and whether it might be cheaper at one provider organization or another. Ideally, of course, that cost information would be paired with quality information on the same services, and that's something that we'll have to talk about and watch as it develops. And then finally, I want to say a little bit more about the limited and tiered network plans that were referred to earlier. Those plans are specific enterprises trying to educate patients about differences, both in quality and cost across providers, and to make them sensitive to those differences through the use of differential co-payments, cost-sharing structures. So as noted earlier, today it's very difficult for a patient to get information on what a procedure is going to cost, what an entire episode of care might cost them, and next to impossible to get comparative information. So for example, if I were going to go to deliver a baby at Mount Auburn Hospital versus Emerson Hospital, what would it cost me, given my benefit design in the health insurance plan that I have today? There is some information available for major procedures by hospital now. Very little information available at the physician or medical group level. But many employers are taking this into their control and actually outside of their health insurance plan, getting information and decision support for their employees to help them choose where to get care, and also just to be able to predict what it might cost them out of pocket. One of the vendors that's doing this is Castlight. David referred to them earlier. So as I noted earlier, health plans in Massachusetts and perhaps elsewhere in the nation will begin to offer this kind of information, perhaps through a vendor, but also developing their own tools using their billing data and the information they have on individual patient benefit design, so they can actually track where a patient is with regard to their deductible and what the contracted rates are across providers. They can really precisely tell a patient how much it's going to cost to get something done at a particular provider. So just to give you a sense of what some of this might begin to look like, this is a screenshot from the Massachusetts Quality and Cost Council. They have a website called My Healthcare Options. So this is a publicly available site. Anyone, anywhere can go to this site. And these data, as I mentioned before, these are the data that are not specific to my insurance plan and my deductible, but they give a patient an idea about the range of costs at different providers in the Commonwealth of Massachusetts. And I just picked, for example, a CT scan here. This is a CT scan of the abdomen with contrast, and it shows for a couple of hospitals that happen to be close to my house what the range of payments to those hospitals for that particular procedure is. So you can see right away, first, that compared to a few years ago, this is fairly advanced. Consumers can go in and search just like they would shoes on Zappos, but the information is probably not that consumer friendly at this point. Do patients know whether they're likely to need a CT scan with contrast or without contrast? And do patients have any idea in that blue line, the range of costs, what they're really likely to pay? These are payments to the hospitals rather than what the patient's out-of-pocket is going to be. So in many ways, a good start, but limited in terms of actionability for patients. So what is transparency likely to bring about from the practicing physician's perspective? Well, first I would say that, as I noted in the previous slide, we're at the very early stages of cost transparency, despite the fact that there is quite a bit of activity in this area. Today, it's not that likely that patients will have the ability to find this information and understand it, because it's not yet being presented in the most useful way for consumers. In theory, however, it's likely that patients are going to start getting these kinds of cost calculators from their employers and begin to ask questions about cost. And as benefit designs increasingly include high deductibles, co-insurance, patients will also become more and more price sensitive. It may be that patients begin to ask about referrals to lower cost institutions. So that is what we're expecting. At the moment, we don't have any good data on how consumers use these information sources. There is some concern from other situations and patient surveys that patients may take high cost to be a signal of high quality if the quality information is not provided alongside the cost information. I didn't show you, but in that the cost comparison tool on that website, there's a quality tab, and if you click the quality tab for something like CT scan, it says there's no quality information available on this procedure. So that leaves a pretty significant gap. Either patients can't make a real cost-quality trade-off, or they may, again, make the wrong cost-quality trade-off. The other effect that some have raised some concern about with an earlier transparency initiative in another state is that providers who look at these charts themselves learn that they're at the low end of the price distribution, begin to demand higher rates. So a few words about tiered provider networks, which have become quite prevalent both in the Commonwealth and nationally. The idea around tiered provider networks is not new. Like many of the ideas we'll talk about today, it's reminiscent of a preferred provider organization structure, but in tiered networks, there is an explicit consideration of performance, both generally in terms of resource use, so that's not just price, but quantity, and also quality of care. And these empirical considerations may place a physician or hospital in a preferred higher tier or in a less preferred lower tiered. And then there are co-payment or co-insurance differentials across tiers intended to steer patients towards those providers that are preferred based on these measures of cost and quality. And the idea is both to get patients to go to higher value providers, but also to encourage competition by physicians and hospitals to get into that higher tier, and therefore to either retain or increase their market share. Most major commercial insurance plans nationally have tiered network products and limited network products. So a limited network is just like the preferred tier only, and excluding or having very high deductibles and co-insurance outside the preferred tier. About 20% of employers include a tiered provider network in their plan. Massachusetts, Minnesota, many states are giving preference to these kinds of tiered networks for their government employees and promoting the dissemination of tiered networks more generally. Here in the Commonwealth, tiered networks have become extremely prevalent. As of last year, reports had that Fallon and Tufts had more than a third of their members in tiered or limited network plans. Harvard Pilgrim and Blue Cross Blue Shield were around 10%, but also growing quite rapidly, particularly in the small employer market, which I think is a real indicator of where we are in terms of affordability. Small employers in particular feel the pinch in terms of the cost of increasing premiums. And so they're looking to narrow or tiered networks as a way of preserving the benefit level, but narrowing the group of providers that their patients can see. The evidence that we have so far on the impact of tiered networks suggests that patients do, in fact, for new provider visits, when they're seeking care for the first time with a specialist, for example, that they do avoid the lowest tier of physicians in a physician-tiered network. And that may have implications over time for competition. Finally, I just want to say a little bit about what physicians are really going to need to know about these reforms. It's important to keep in mind that the cost pressures are not just on the federal and state budget, but patients feel these cost pressures too. They are allocating scarce household income, and so physicians should expect that patients will increasingly be looking for assistance in finding higher value options. I think one concern is that if physicians are going to partner with their patients in these ways to think about where money could be saved without harming health, that physicians are going to need access to the same kinds of information that patients have. It's not clear at all that some of these vendors that provide cost information to employees through their employers will make that information available to physicians as well. And without that information, how can a physician know that he's referring or she is referring a patient to the lowest cost provider? As pointed out earlier, the mismatch between cost and quality information is significant. Most of the quality data that we have available, both here in the state and nationally, has to do with primary care and sometimes certain kinds of hospital admissions. But when we're talking about the cost calculators, we're thinking much more about trying to get people to get diagnostic imaging in different locations and other kinds of procedures for which there are no quality data. And then finally, just to note that some of the ACO strategies that Mike talked about may run counter to the tiered and limited networks. If ACOs overlap in a mismatched way, patients may have incentives to go to certain physicians because of their tiered network, while their referring physicians have incentives to send them somewhere else due to their ACO arrangements. A lot to think about in this era of reform.
Thanks so much, Meredith. It's just a fantastic summary of where we're heading on this important issue of transparency. Let me keep the focus for a minute on physicians and ask you, why should physicians see anything good about transparency or consumer tools for finding higher quality and lower cost health care? Isn't this simply going to make their jobs harder?
I think in the short run, Greg, this is likely to cause, because of the potential mismatch between the initiatives that are consumer-facing and initiatives that are physician-facing, I think there is likely to be some tension. However, I would say if we think about the broader goal of improving health and still having some money left over for education and roads, as I'm sure most physicians would want, that the idea of moving towards a more efficient healthcare system in partnership with patients is an important one. And the Choosing Wisely initiative of the ABIM Foundation is an excellent example of trying to think about eliminating waste, controlling costs in a way that engages physicians with their patients. These transparency initiatives really need physician input to help shape them, to help improve the quality information and make sure that the information that patients are getting is consistent with what their physicians would advise. So there's a lot of work to be done, but I think we've learned from managed care, for example, 20 years ago, the backlash caused by essentially keeping patients out of the cost control picture and putting all of the pressure on the delivery system. This is a work in progress, no doubt.
So let me ask you about patients and their response to this. What are patients' incentives to seek out physicians in these higher tiers, which are really based on cost efficiency? What is their motivation for doing that?
Well, aside from the lower copayments, patients may be learning for the first time about the variation in costs across the delivery system. So patients may respond to that information as well. Likely patients are going to begin to ask questions about the quality of care. So for example, if I'm being encouraged to get my procedure at a particular hospital because of a tiered network, patients are going to begin demanding information so that they can make sure for themselves that they can appropriately judge quality and not make what seems like a good short-run financial decision that would ultimately be a bad longer-run decision. As far as we know in terms of consumer behavior to date, however, I think what you may be pointing to is that consumers have been not that interested in being engaged in making these sorts of decisions in the past. They have not been very active users of quality information. I think that will change when what they pay is on the line, and we hope that that will encourage them to ask the harder questions about the quality of care across these places.
So one last question, Meredith. I'm sure that you saw a recent article in Time magazine written by Stephen Brill, which highlighted, first of all, the lack of transparency on pricing of medical services that you've been discussing here, and also the sometimes exorbitant prices that are being charged, really without the patient's knowledge up front, sometimes even at not-for-profit hospitals. Can you respond to this article and tell us a little about what impact this might have?
Well, I think that this question of transparency in healthcare goes beyond how much is a scan Dr. Smith versus Dr. Jones going to cost me. But I think you're right that the Brill article points to the lack of transparency overall, not just in the level of prices, but how those prices may vary by consumer, what those payments that are triggered when a patient, for example, gets a test in a hospital versus an office, or in an office that happens to be affiliated with a hospital, which I think was part of what that article highlighted. This has the potential to raise questions around trust of patients in the delivery system. And I think it needs to be met head on by hospitals and physicians. And we do need greater transparency. It's fairly clear that patients are unaware of the pricing structure in the delivery system. And obviously there are some reformers out there who would like to see more of that come to light. I don't think that it can just be buried. So we're going to need to think of a way to make those pricing structures fairer and more transparent.
Fantastic. Thank you so much. And thanks to all of the panelists for very illuminating presentations. Let me ask one last question of all three of you, and that is, what will things look like in 3 years? And Mike, let's start with you. In the ACO space, what will things look like in 3 years?
Well, I think broadly, we are going to continue to move away from the fee-for-service system we have, because I don't think providers are going to be able to survive in the rates that they're likely to face. What that will mean is a lot of activity in provider systems, both to change their configuration, reorganization, integration between physicians and hospitals, between hospitals and post-acute settings. So a lot of change in the organization and a lot of activities within the organizations to figure out how to manage populations as opposed to how to deliver services. So there'll be a lot of advances in information technology. There'll be a lot of advances in how different types of workers are deployed, a lot more emphasis on population health and other types of outreach programs relative to where we see now. And it's simply going to be a question of how rapidly the system can transform itself and how willing the organizations are to change. I personally predict relatively rapid movement as opposed to sort of slow incremental steps. Here in Massachusetts, the movement has been actually quite rapid, but that remains to be seen.
Thank you. Now, David, in 3 years, Is this spending target in Massachusetts going to be reached?
I'm an optimist, so I believe yes. But let me give you a story that I think is apocryphal. Most physicians who have transferred their practices from paper records to electronic medical records say that the first 9 months or so was just awful. You know, they couldn't figure out what it was doing. They had extra work. It was wasteful, duplicative. They cheated whenever they couldn't figure out what to do and went back to paper records. And yet by 6 months after they had made the transition, they were much happier. And they vowed they would never practice again with paper records because they finally saw what the electronic records could do for them. I think, and I suspect what we're seeing is exactly that writ large, which is that there's going to be probably more than 9 months, a year or 2 years of very difficult times as folks figure out how to transition their practices, how to do better at prevention, how to avoid wasting resources and so on. And it's going to be very difficult, and people are going to be tempted to go back and cheat and all of that. But that a year after that, people will be happier with their practice and say, I'm glad I did it. I feel like my patients are getting better care. I feel like I'm practicing better.
Well, as I said earlier, I know you're an optimist, and I always appreciate that quality in you, David. Thank you. Meredith, in 3 years, are patients going to be using these tools to look at information about their providers?
I think some patients will be. And so the cost control scenario of 3 to 5 years from now, I think, includes some elements of consumerism. It's my suspicion that we'll see these tools spread widely. There'll be some educated consumers that are very active users of these tools and who, for commodity type services, that is, a scan, for example, an endoscopy, that we'll see a much greater price sensitivity and we'll see prices come down. On the other hand, I think when it comes to thinking about critical health decisions for very ill, vulnerable patients, consumerism is not going to be the way the world looks. And so I would imagine that commercially insured, relatively well individuals, that's where the consumer tools, the tiered networks, cost sharing with information will really penetrate. And then we'll see for older folks as well as other people with chronic disease that these care management integrated solutions that don't involve provider shopping, that will be where the emphasis will be for those populations. So yes, but not everyone. I don't think consumerism is intended for everyone or is likely to be successful in that way.
Thank you, and thanks to all three panelists. And at this point in the program, we want to open this up to questioning from the panelists to themselves, to each other. And why don't Michael, you start? Do you have any questions for your colleagues?
Well, I'll start with a question for David, which is, in this discussion, it's clear that increasingly we demand excellence from our providers and our other delivery systems. Do you think our ability to demand excellence from the regulatory structure is there? And do you think we're going to be able to have the government systems that wrap around this delivery transformation work at a high level to push us forward, or become a barrier to actually some of the transformations we need?
It's a great question, Mike. Should we demand excellence from our overall government regulatory system? Yes. Will we get excellence? It's interesting. Everybody hates Washington. Nobody trusts what happens in Washington. But people are more comfortable with actions at a state and local level where they can sit down and figure out how to make things work jointly. And so there's much more of a kind of government as community as opposed to a government as extractor kind of feel. And if you look at governors, they tend to be a bit more in touch with what's going on the ground than, say, typical legislators or members of the executive branch can be. So I'm more hopeful that we will be able to do some of these things at a state level than we've been able to do at the federal level. But that much said, I think the provider system is going to have to be involved in the operation of the public sector and really getting involved so that it's a partnership, not just a regulatory effort. And I think in Massachusetts, the way that we've thought about it is really as the government as a partner rather than the government as a regulator.
I have a question for Mike. In thinking about the AQC and other ACO models, most of the participants to date have had a hospital in the middle of them. What is that going to mean in the long run? If those efforts are successful, costs have to come out of the hospital. What is going to happen to the hospital business model?
Well, I agree with that, and I do think that's a wonderful point, and I think it emphasizes the notion and the tension we face now about where the control lies and where the savings will go. Will they go to the hospital? Will they go to the physicians? And if they go to the physicians, will they go to the specialists? Will they go to the primary care physician? Most of the models of the ACOs that I have seen are fundamentally primary care centric. So, for example, in the alternative quality contract, the organization that gets the money and therefore gets to keep the savings is the organization that employs the patient's primary care physician. In the assignment for federal ACOs, the patient is assigned to the organization that has provided the most evaluation and management services. I think the traditional conceptualization of the hospital as an organization and the physicians as an organization being separate with separate financial interests segments the patients and segments the care in ways that do us a disservice. And so I think we should think about the hospital as an input to providing high quality care and hope that even if the hospital per se becomes less financially viable and must change its structure and its use of workers and what it does in various ways, that the organization that includes the hospital can in fact be viable, because under these new models, in fact, that broader organization can keep the savings. Every organization, be it hospital-centric or not, will require hospital care. Every organization, be it hospital-centric or not, will require primary care, will require specialist care. And I think we have to worry a lot more about the success of these integrated organizations than the success of any one piece, because our desire to keep each individual piece viable leads to inefficiencies that I don't think serve us well in our efforts to transform the system.
Great. David?
I'd like to ask Meredith a question actually about how consumers are going to interact with the medical system in the future. So Kaiser spent, $4 billion on an electronic record, and now an enormous number of visits take place through email and messaging instead of through face-to-face contact. Iora Health will hire 4 health coaches for every doctor and work with people that way, and says that for 5% more on the primary care end, they'll save 15 to 20% on the back end. The great writer John Cohen wrote an article in The Atlantic, the magazine, the title of which is "The Robot Will See You Now," which is basically, do you even need to interact with your primary care doctor, or is Watson, IBM's Watson, going to do everything for you? So is this the beginning of a revolution that says that the relationship between the patient and their doctor is not going to mean very much, and that people are going to seek out health in the way we seek out buying things over the internet, which is very little affiliation with any particular company other than what we want, or is that overreaching here?
Well, I think that's probably a little bit overreaching. It's true that we've been looking at primary care models that use all of those non-physician sources of care that you've described, care through the electronic medical record, through the personal health record, on the phone, with a much broader set of team members, including community health workers. And it remains to be seen, in my opinion, looking at the research, the extent to which patients are enthusiastically engaged in all of those kinds of care. The Kaiser results are perhaps the one example that seem to have demonstrated that patients really do seek out those electronic visits. I think this is, again, a work in progress, and when we've looked at those primary care transformations, the patient reaction has taken a lot longer to get in place than for the physicians and other clinicians to begin to work as a team themselves. So I think that we'll see a good deal more of that, particularly when there are cost incentives associated with it, which there may well be. But I don't think that patients are ready to give up their physicians. Everything we know about the way patients seek information in healthcare suggests that they value that physician relationship, that they value that physician as a source of information, that they're not quite ready to go completely to Zappos. When we try to get them to use statistical information to choose a surgeon, they tell us they'd rather ask their primary care physician. And so I think that that's not going away. But, I was going to ask you along the similar lines. I've heard you say in the past that that the healthcare system could learn something from Walmart. And I wonder how much innovation on the delivery system side you expect to see here in Massachusetts. We have, as you know, retail clinics, and there are other models of care. Do you think those are likely to take off with health reform?
I think they are likely to take off. It's one of the for many patients, the most difficult part, the most expensive part of accessing the medical care system is the time and the money involved in going to it. I mean, if you have good insurance, and let's say for primary care, so the inconvenience is enormous. And you take that, and you take a very technologically literate population that says, why can't I email my physician, and why can't I agree, I'm not prepared to give up my physician entirely, but why can't I do other ways of doing things? And you come back to Michael's comment that while you need the hospital, you don't need the hospital all the time. You really need it only for very specialized things. And that suggests a big decentralization of what's going to happen. And I think the people have shown they're willing to pay a fair amount of money to get the convenience and the sort of immediateness of it. And whoever can offer that will really do extremely well for them. And oh, by the way, it just turns out to be a whole lot cheaper as well.
Michael? Yeah. So I actually have a question for Meredith, which is, in the current system, insurers and often employers are the organizations that control the incentives that the patients face. They control how much they pay, when they pay, where they go. As we move to a world where there's payment reform, the delivery organizations are bearing a lot more of the risk for what happens. Do you see a role for those organizations in trying to determine the incentives that their population faces, or do you see us in this system where the incentives are devised by one set of organizations, but the risk for behavior and the outcomes from those incentives are actually borne by the provider system?
Yeah, that's a great question, and I've often thought that some of the chaos in our delivery system is a result of the fact that employers make all the benefit design decisions, and they make all the wellness incentive decisions, and then the health insurers and the public payers make all the payment decisions, and they never seem to talk to one another. I think it's a really interesting question. I know one example of there are at least rumors that groups in California that are serving as as ACOs, they have one set of patients that come to them through traditional Medicare, and then they have one set of patients that come to them through a Medicare Advantage model. Very different sets of constraints on those patients, making it easier or harder to manage those populations. And I would think that providers taking risk for a population would begin to demand to have some control over that lever, because you can imagine there are lots of counterproductive incentives that patients could bring with them into an ACO. I think it'll depend a little bit on negotiating power, or I wonder if it's a question for public policy. But, I think a prime example is perhaps providers taking risks for a population will insist that the patients all be in HMOs.
Can I turn that question slightly and ask a version to Michael, which is, one of the immense trends we're seeing is that physicians are going from independent practitioners to employees. And very few young doctors are independent.
Absolutely.
They're almost all working as part of a big system. I don't know, maybe they like it, maybe they don't know what the alternatives are. Are there any consequences of that beyond the obvious, which is just someone else is writing their paycheck and so on? Are there any favorable or unfavorable consequences of that we ought to be aware of?
Yeah. So I'm going to ignore the obvious issue that in the short run, payment rewards some of that integration in ways that might not be equitable across sites of care, and focus on broadly what I think is a positive aspect of that. As the healthcare system becomes responsible for population health, and as the technologies to manage populations become expensive, information technology, registries, a series of outreach programs, I think it's increasingly difficult for physicians in small independent practices to handle that entire scope of care. In Massachusetts, we have large systems, and I think they have a lot of capabilities. In other places where you don't, there's an insurance company, Care First, that's doing a range of very innovative things virtually across the practices. But the point remains that I believe this type of closer integration enables the organizations to employ cadres of people who can manage above the actual office visit to try and put in place the incentives to reach out to the patients in ways that the physician wouldn't have time, and frankly is not what the physician needs to be able to do. And so I, generally speaking, view that integration as positive. There are a lot of concerns in any situation when professionals work for large organizations. How well can those organizations create their internal incentives? How well can they incent physicians to work hard as opposed to not work hard? There's a broad field of management about how large organizations incent their workers. So I think it's important to understand that while a lot of this discussion sounds like it's very positive on the future, I think we would be remiss to recognize that there aren't real risks, that these bigger organizations will simply fail. There can be simply bad management. There can be physicians that do not feel that their incentives are aligned with the incentives of the organization. There are a lot of very complicated managerial concerns. My personal view is recognizing the difficulty of this transformation, and I very much agree with your statement earlier that there's going to be at least 2 years. That was knowing you're optimistic. That's why 2 years is optimistic. There is likely to be a lot of tumult as this transformation happens, and success is by no means guaranteed, but I think the alternative of small practices caring for just parts of a patient with very little incentive to coordinate, very few resources to adopt these types of broader tools is probably a worse outcome relative to this. And should this outcome fail, a question that wasn't asked to us, and hopefully we're at time so you won't be able to ask, is if we are not successful along this means, then what? Because the answer, I think, is not we will simply put money into the fee-for-service systems and go back to where we were. The then what is likely to be more draconian in a whole number of ways. So let's hope with this level of energy across the board, and I sit on a number of panels where I think I perceive anyway remarkably less hostility to these types of transformations than I perceived in the 1990s when there were actually in many ways similar transformations. You see a much greater willingness of providers to engage the system on this journey than you did in the past, and I believe the reason is because they're increasingly understanding that if they don't, the alternatives are very bad. One of the obvious concerns in accountable care organizations is that the incentives that exist would suggest that physician organizations would be encouraged to not provide sufficient care. There's a number of aspects of ACOs that cut against that concern. Perhaps the most important is that physicians want to do the right thing. Of course, there's other aspects of ACOs as well, There's quality measures that reward physician organizations for doing the right thing, and the organizations themselves actually have incentives to keep their patients healthier. They save money if their patients don't have heart attacks. They save money if they can keep them out of the hospital or away from the physician office because they're healthier. So while we have to monitor the quality of care in accountable care organizations, I think there's at least some cause, including at least a little bit of evidence, given our limited measures, that we can have high quality and lower costs in these new types of models.
I want to thank all of the panelists for a very scintillating afternoon, and we look forward with great anticipation and great expectations to see what happens in the coming 3 years. Thank you very much.
Thank you.